and our last speaker, who has really been great in I2B2 overall, and we've had a real workout with her adopting some of what we've done and contributing a great deal of her insight into creating the Florida digital twin. So Gigi Lipori, the Senior Director of Research Informatics now at University of Florida. CTSI.
It wasn't just me.
No, it's not just you. Let's see here. Rack is working. Joe, we might need your help.
Griffin, you broke it.
Oh no, I think you got it. Okay. This is you. All right.
Oh, you got it.
Go.
Great.
Right.
Well, hi everybody. I'm Gigi Lipori. I was the long-term CIO at UF, and I just stepped back into a research role a couple months ago, which is actually a fun place. Being a CIO for 8 years is a long time, and cyber criminals are make you have gray hair and lose sleep. So I thought I'd tell you today something a little bit different than the other stories of things that we have in Florida that are quite different. We have something called One Florida Plus that I'll talk about in depth. It gives us a huge population of patients over a wide geographic area. And I'm going to use an article we published on that about red tide that was published by actually some of my colleagues to make a simple point about having what the EHR allows you to do and then what you need on top of that to use for public health in terms of clinical events to exposures and geography and timeline. So the thesis is really that the EHR data becoming public health infrastructure when clinical events are linked to environmental exposures, geography, time, and governance. The record tells us what happened to a patient. It doesn't tell us by itself a public health story. For that, we need to know where someone lived, what the red tide concentration was that month, what else happened in the community that month that might explain what we were seeing. The clinical data answer what happened. The public health also has to answer where, when, why, and potentially what if. That last piece of governance matters more than the data. So the whole talk is about moving from a one-off cohort polls to a reusable, governed set of models. So why Florida? We actually have many of our public health events are really related to things in the environment. So they're seasonal, they're tied to decisions people are making now about where and how we live. Red tide is a clean example, but the same example exists in Jacksonville, where we have a digital twin of the low-lying areas and the shallow wells there that occur, what happens when flooding occurs, and what type of coliform is exposed to the community and what happens there. In Jacksonville in particular, that becomes important because as the coast is growing, the officials are trying not only to answer, can you pull a cohort? They're asking, what should we do with it? What should we do? How should we plan? Where should we build? So One Florida gives us a very large base. It's 31 million patients. It spans Florida and a couple other states. It has public health value, and we link that base to everything else around it. And that's where we kind of move beyond describing what happened and beginning to understand what may happen next. So it's about 70% it covers about 70% of the population of the state of Florida. It's pretty big. It also, oddly enough, has Emory and has UAB and a few other places around in that area as well. So the substrate is the One Florida clinical data. It's large, and it's built for reuse. We ingest everything centrally into a CoreNet model, and then we render an OMOP model from that. And we expose the data via ITB2 via the OMOP model for convenience. Those things sit very much side by side, so we can use Atlas or OMOP. We can use Atlas and ITB2, and then we use our supercomputer to do a bunch of other analyses and machine learning. The data trust, it also includes all the Medicaid claims from Floridians. So that's pretty important in terms of continuity of patients over time and population level analysis. We have a digital twin pattern where we try to look at clinical events in external context. So in this case, we took the One Florida data, and then we looked at exposure in terms of red tide, water, air quality, wind, all those types of things that happen naturally, place and time, other covariates, socioeconomic status, access to care, access to food, and eventually trying to come to a causal model. So what comes out on the other side isn't just a p-value, it's a kind of a disciplined estimate of what we think happens because of red tide in the state of Florida. Dr. Wang and Dr. Gao published this paper for red tide plus One Florida, 138,000 residents between 2012 and 2019. It had all the linkages to do that, and then they brought together a bunch of environmental data, coastal zip code concentrations, and didn't really stop at an exposure level outcome, but really looked at demographics, clinical air quality, wind, social environmental factors, and applied a causal framework to that to try to get to generalizable estimates. What the evidence did show, just kind of the short story, there are three things that people hypothesize that red tide does. One, that it affects respiratory disease. Tree chipping, nice. GI outcomes and neurological outcomes. It's interesting, we did find some increase in acute respiratory outcomes and some in gastrointestinal, but really negligible in neurological. And that's really, people have really focused on that in the state of Florida about what does this really do from a neurological perspective. So it's kind of a what this means and what this doesn't mean study. And that was well accepted by the community. So what changed? What's difference for this versus our other work? The data set stops just being a data set and becomes a reusable model. The one-off pull answers retrospective questions, and then it's done. A model you can reuse later and say, what if the coast keeps growing? What if exposure worsens? What should we staff for? Where should we focus resources? And that type of thing. So to make it concrete, for that about 400,000 people, it correlates to about 1,320 additional respiratory diagnoses, 480 GI diagnoses, and not much more for neurological diagnoses. So the lessons that we had from this is that common data models are necessary, but they're not sufficient. So we actually use ITB2 on top of OMOP, CoreNet, Atlas, Shrine, all those types of things to get to our data. They're complementary layers or not competing camps. And I think that that's something that's really important because people try to look at OMOP versus ITB2 and say, oh my God, they're competing. And we're trying to convince people that that's not the case, that they actually work together and we need to work together and they both have value. We have that internally at UF with the One Florida consortium data and then the internal data that we have. The One Florida is really, really, really wide, 31 million patients, but it's about as shallow as you can get. It's, maybe 500 governed data elements. If you look at the UF Health data, and internally, it's about 4 million patients, but there are 27,000 governed data elements. So they're just different things, and they work together, and they have different purposes, and that's important for people to understand. So the hard part was really matching the architecture to the question. The red tide model leans on Florida geography and environmental data. Griffin's work has a completely different set of data flows. Jamal's Enclave answers a different set of questions, and Bill's Explorer is a different model altogether. So the opportunity with us as CTSA sites is to reuse that pattern without flattening the local context so that each of these work. So there has to be this construct in the middle that works, that's standard, but there has to be room to be able to pull in these other elements ad hoc on things that are applicable in certain environments. And that's really the tricky part to try to figure out so that we end up building really a environment that can continue to grow and provide purpose over time. So I'm the last presenter, so I thought I'd just go ahead and throw up a couple questions and then turn it back over to Sean. But some of the things that I thought of is how should we choose the right architecture for the use case, federated, centralized, enclave-based, or locally governed? I think they all come into play. When does a common data model become more than a research asset and start functioning as a public health asset? And how do we reuse these digital twin patterns across sites without flattening the local context that makes them valuable? So thank you.